everybody, and I'm thankful to ISCCM. We both are thankful to ISCCM for giving us the opportunity for this program on structured training and education program for the nurses. It is an excellent initiative from ISCCM. Last 2 years, it is doing fantastic job in every fortnightly, and today in this Thursday we are here again for a wonderful talk on bed sore in critical care, and the speaker is my dear friend, that is Prateek Koolwal, and he has done his MD and FNB in critical care, and is now consultant in critical care medicine EACC Hospital Jaipur, and he is an excellent speaker. I think you all will be benefited in this session. Over to you, Dr. Prateek.
So, good afternoon, all. Um, so, the topic is important, and we deal with it in a day-to-day life, in a day-to-day in the ICU, exactly in a scenario, but it can be seen in the home care settings also, outside the ICU, in the ward, long-term patients in the hospital, which get to this condition of a bed sore in critical care, which is my topic of today. So thanks, first of all, thanks to the STEP program who given me this opportunity for as a speaker in this structured training and education program. So we go on with the slides, and after that we have any question, we put in a chat box, we take by one. Okay, so we go on with that. So bed sores are also called the pressure ulcers and the decubitus ulcers, injuries to the skin and underlying tissue resulting in prolonged pressure on skin. The pressure ulcers have a significant impact upon a patient's morbidity, mortality, and quality of life. Cause of concern for both patients and their families, as well as for a health and professional healthcare system. So I'm audible to all. Am I audible and my slides are clear? Yeah. So, okay. So, yeah. So, the prevalence, the how much we see in a day-to-day this bed sore, it's 4.7% to 32% we see in hospital population and 22% in nursing home population. Surveillance showed that pressure ulcers of grade 1 to 4 was 18.1%. And if grade 1 is excluded, then it is 10.5% we see, which is very in a number which we see. Sacrum and heels are most affected locations, and cost estimate treating it's in the international amount, but it can be seen that it costing increases to 20 to 30,000 if the bed sore occur in Indian settings. It's pounds of 14 in grade 1 to 14,000 pounds in grade 4. So pressure ulcers pathogenesis, if we see, it's seen in the pathophysiology in a bed wheelchair settings, the patients on a bed and a wheelchair, patients who are involuntary muscle movement or a passive repositioning of a torso at the back, and inability to move well. Bowel and bladder incontinence also lead to the pressure ulcers, and decrease in movement of mainly in the neuro settings. We see the pressure ulcers are most common because they doesn't know and they doesn't feel the sensations that having a pain or eroding of the skin is there or not. So if we these ulcer occurs or this pressure ulcer occurs, so it causes an external physical compression, shear forces, friction, pressure, and limited mobility. It also seen that if the pressure is more than 32 mm Hg of the capillary pressure, which is more higher pressure above, can lead to the increase in a pressure ulcers. It disrupts the blood vessels and deprives the tissue from the oxygenation point. It can lead to many stages like stage 1, stage 2, stage 3, and stage 4. Stage 1 is a non-blanchable erythema, which can be seen in a reddened area, which is the most seen in an early part. Stage 2 is a partial thickness skin loss. Stage 3 is a full thickness skin loss, damage to subcutaneous tissue damage, but not involving the fascia. It's a skin, epidermis, and the subcutaneous area. Stage 4 is a full thickness tissue and can be involved of a bone, muscle, tendon. In this part, in stage 4, the pain is very less, But stage 1, stage 2, stage 3, the nerves are intact, so pains are very much is there. So as we see in a structured way of a pathogenesis, is unrelieving pressures disrupts the blood supply to the capillary network, depriving of tissue of oxygenation, nutrients, and block the nutrients, return of metabolic waste, complete inflow impairment, which lead to the ischemia, because if the blood supply will not, it's getting compressed to above the pressure of 32 mm of Hg, will cause the ischemia and tissue damage and can lead to pressure ulcer. So this is simple staircase pattern of applying getting ulcer. So this is schematic diagram how the stages present. Stage 1 is a non-blanching erythema with intact epidermis. Stage 2 is a partial thickness ulcer involving epidermis and dermis. Full thickness ulcer extending to the dermis and subcutaneous tissue, and deep to the part involving the bone and muscle and a bone and tendon. Stage 4. Some bed sores are suspected deep tissue injury, but the skin is not eroded. Internally, it's getting eroded. So purple maroon localized area is seen of discolored intact skin or a blood-filled blister due to damage of underlying soft tissue from pressure and shear. So you can see in this the skin surface is intact, but the purple and maroon localized area is seen. Deeper and deeper you go, damage is going on. So you have to be quite vigilant in this case. You can't be saying that this is stage 1. This is not stage 1. This is getting up below the stage 3 or stage 4. That the tissue is getting damaged deeper and deeper inside. So it's unstable pressure sore. This pressure sore can't be seen in any of the stage. There's no sludge in any of the stage 1, stage 2, stage 3, or stage 4. But if you see the sludge is there or a sharp formation is there, this is unstable pressure ulcer, which is very difficult to manage and need a long-term management is needed. This is a National Pressure Ulcer Advisory Panel, which is seen stage 1, stage 2, stage 3, stage 4 in the same pattern as I have shown in a diagrammatic point. So what are the contributing factors which can cause the pressure ulcer? The pressure itself, friction. In day-to-day, you see when the nurses or any person or a physiotherapist or any person in the ICU shift the person, there's a draw sheet is there. If you don't remove or don't pull a patient from the draw sheet, if you friction it, it will cause more damage of the skin. So you don't have to drag it, you have to pull it, and then you have to take up to take the patient up. So there is friction or shear. Again, the patient is going down, the intubated patient getting sloped down in the bed. You have not maintained the proper position of the boat shape position in the ICU. Then patient is getting shear injury of the back or a bony prominences. So the risk factor is mechanical boundary conditions, magnitude of the mechanical load, time duration, how much load is there, how much pressure is there to the part, or type of loading, that is shear, pressure, or a friction. This is called as internal strain stresses that is occurring on the tissues. What is susceptibility or tolerance that can cause or that increases the threshold of the pressure is individual mechanical properties. If the skin is its leg, if the skin is very loose, then it will increase the chances of pressure ulcer. Geometry of the tissue or bone. If the patient is malnourished, the bony prominence is very prominent, then it will increase the chances of pressure ulcers. Individual physiology and repair. The patient have a malnutrition, have a repair the repair is not as more than as the patient of tissue damage, then it will increase the susceptibility. Individual transfer of and thermal properties. If you attach some patient needs a warmer, if you attach the warmer to directly the tissues intact area, it increases the chances of the pressure ulcer. So these are the risk factors to increase the pressure ulcers. The things that you see in the dark, it's more common, will increase, which take you to the outcome of the pressure ulcer. Increase in mobility, skin pressure ulcer status, and poor perfusion. This most common can lead to the outcome of the pressure. If continuously this is going on, then it will increase the chances of the pressure ulcer. This is another classification, that intrinsic classification. Intrinsic can lead to the risk factors of the pressure ulcers, and extrinsic and the small thing of extrinsic point of view. So mainly the thing is the intrinsic that you know the comorbid diabetes patient is more common. Decreased pain sensation in diabetes patient is more lead to the pressure ulcers. Use of corticosteroid uh, in the ICU. This is most common thing is seen in the ICU. And extrinsic, the pressures, the frictions, and the moisture. So most common site we see is most commonly supine position, mostly in 23% sacrococcygeal and sitting in 24% in ischium, lateral in a 15% trochanter. How you prevent it? Ulcers are occurred in mostly in the buttock area, mostly in the shoulder point, mostly the back, mostly in the trocar area, hip joint, mostly in the ankle area, in sitting position, mostly in the buttocks area. So how you can prevent it? So risk assessment, first of all, have some scoring scale. I think in every ICU, the nurses are doing a scoring in every day, twice a day when their duty shift changes in every 6 hourly or 12 hourly, whatever their duty changes, they see the risk assessment. Then skin assessment they have to do. How much is the ulcer? What is the size? It increased or decreased? It's soggy, it's moist or dry, the erosion is there, the bleeder is there or not, it's getting dried up or not. This you have to assess. Prevention measures, that the air mattress is there. If there's a skin erosion is there, you applied the any supportive you have done, any pressure dressing is you have done that is there, then you have to loosen the pressure dressing. Any Maplex is there, that is hydrogel is there, you have applied or not. And the treatment of if the ulcer has occurred. Just a sec. So risk assessment. So this is a Braden scale and a Norton scale and a Waterlow scale. So mostly the scale overall that is used is a Braden scale and the Norton scale. And then lastly, it is Waterlow scale, which I used in IICU is a Braden scale. So Braden scale is easy to learn. As you go higher and higher in the score, the things are getting improved. It is milder risk of getting an ulcer. If the score is very less than 9, that is high chances of getting a pressure ulcer. So I'm not telling the whole of the score. I think everyone is evident. I think the analysis is evident of the Braden scale. And this is a Norton scale. In Norton scale, it is it's similar like to Braden scale. As you go, the lesser it is, it's very high risk, and as you go the greater and greater, it is low risk. And the Waterlow scale, as you go to the lesser the points, it's at risk patient, and it's go above the point, it's very high risk patients. So what is the evidence of the risk assessment? I can only point out, I know it's difficult to read and difficult to imbibe anything from this, but the thing is that every scoring that you do is nothing significant and nothing shows that it will increase the chances that you can decrease the chance of ulcer in the ICU or pressure ulcer in the ICU. So no any scoring is done. Whatever is feasible in the ICU, you can use that. So how you prevent it and how you manage it, it's the most important thing. Prevention is more than if you avoid it, then it will decrease the cost effectiveness of the ICU. So the most important is that you have to prevent it rather getting engaged with it and then you're managing it with increase the cost in the ICU. So how you prevent it? You give the good nutritional support, frequent repositioning, support surfaces, preventive skin care, application of skin and protective dressing, clean and debridement. Role of nurses is the most common and the most important in this. So the evidence of nutritional support is that supplementation is to be given, but it has very low quality of evidence. But if you give the supplement, it doesn't show that rate of development of pressure ulcers decrease, time of development of pressure ulcers decrease, time in hospitals is increased. It is NHS is the UK based. It is also not seen in the UK that you use a supplement and it decreases the pressure ulcer or health related quality of life. So supplement of high amount of micronutrients like arginine, zinc, antioxidants, most of it is used in the ICU. So it doesn't mean that if you use it, the chances of ulcer is less, but yeah, it increases the immunity power. So you can decrease the chances of ulcer formation. Second is a positioning issue. We use our nurses do daily routine in every in their every shift. And adopt the repositioning protocol and based on the patient's level of autonomy, if the patient is awake, if the patient is conscious and following command, and if the unconscious patient, the lateral decubitus position is mostly done, which I show in my picture in our following slides, and any repositioning must be carried out by switching from one side to other in accordance with the clinical condition of patient. If patient is NORAD, you can't keep in your patient in a decubitus position. You have to keep your patient in a supine position, but you have to seek for the ulcer formation or pressure ulcer formation because NORAD or vasopressors will causes the vasoconstriction of the vessels. So it will increase the chances of the ulcer formation. So this is the position of different, how upper limb positioning is done, how is lower limb positioning is done, how is head positioning is done, how is prone positioning is done in the ICU, and the supine position is done in the ICU. So this is done in a ventilated patient, which is seen in our ICU. In early mobilization, it's also important. Active and passive mobilization intervention are aimed at recovering the muscle tone. If early mobilize the patient, it's a respiratory patients are most common seen in the ICU with other consecutive other associated diseases. May have the patient have a respiratory failure also. So this is the most important thing that patients need to be early mobilized. It will increase the chances of the perfusion and will less chances of ulcer formations. Support surfaces that we use in our ICU. At-risk patients should have used the air mattresses. Use a viscoelastic foam mattresses if it is not possible to reposition a patient at interval less than 4 hours. Skin protective dressing. I think everyone in the ICU use this dressing in sacrum area. This is hydrocolloid dressing, and this is silicone foam dressing, which is used in a bony areas. It will prevent the ulcer formation in the bony area, which is most common when the patient is long-term supine or in a bony prominences are most common. So dressing protocol is a check the assess under dressing at every shift and document of the finding. Peel the dressing back, assess and reapply again. You don't, if it is doesn't like that, you have applied the dressing and then you forgot it. No, you have see the dressing again in every shift. The nurses have to see it in the dressing with the doctors is there on around that what is the dressing is going on. So in AORN guidelines 2017 recommend use of preventive dressing on bony prominences or other areas of subjective pressure and friction and shear forces. Cleaning and debridement. If you see the showcase is there, you have to clean it and apply the dry dressing is there. A simple rule is that if there's a wet ulcer is there, you have to apply the dry dressing. If there's a dry area is there, you have to apply the wet thing. So that things can be, because dry is there because skin is dry. Friction is causing that ulcer. So you have to apply the wet thing or any foamy gel is there. So stage 1 wound can be gently washed with water and mild soap, and preferably antiseptic agent should not be used, and debridement are required only in stage 3 and 4. So this is a thing that shows in a bony prominences, mostly in a head part in a occiput region, and is healed. We done the dressing and the debridement is done. This is a calf. This is a calf muscle which is getting eroded. So if the skin flap is attached, and then it causes the improve the area. Another therapy which is not generally some centers have, some centers doesn't have, it is hyperbaric oxygen therapy, but you can do it. You can't apply if you don't have a machine. So you can give the oxygen therapy with your oxygen flow meter at 7 to 8 liters or approximately 10 liters per minute, getting towards the 50 or 60% of oxygen to the ulcer area. So it will heal. So what oxygen will do? It will neovascularize and improve the post-ischemic tissue survival if you give the oxygen to that. What's the role of nurses? Nurses should continuously assess who is at risk of the bed sore. So they should know that who patient can go to the ulcer formation. If the patient is supine for a long time, they should know that. They should tell to the doctor on duty that the patient is prolonged, we need to change, or this patient at risk, or to the concerned is coming on the duty with a daily duty. The predisposition factors for the bed sore development: skin condition at least twice a day they have to assess, inspect each pressure site, palpate the skin for increased warmth. need it, and you have to do it. The role of nurse is that you can't avoid it. Inspect for a dry skin or moist skin or break in a skin. You tell to the concerned doctor on duty. Evaluate level of mobility. You tell, and you evaluate the circulatory status. The patient is high NORAD vasopressor status. You have to tell it. Patient is more prone to the ulcer formation of bed sore. Determine the presence of incontinence. If patient is having continuous stool is there and you are not cleaning it, you keeping the area of the buttocks area moist, then it will increase the sacral area to the most common chances we see in a daily routine of a bed sore formation. Evaluate nutrition and hydration status, not present in health problem. Prevent it, as I already said it, you have to prevent it, rather you have to treat it. Intervention for the patient with poor nutrition, provide adequate nutrition and fluid, assist it with intake as necessary, and consult dietitian for nutrition evaluation. Other interventions that you have to see, that is evaluate ulcer progression every 4 to 6 days. And educate the family. You don't, the first of the family is getting worried of that ulcer is forming, sir. How to do it? This is the hospital is doing it, or it's a treating or not. I have to calm down. Yeah, it is a process. Some patient agar it, old age, most common. The patient high vasopressors, most common. Patient lying down, most common is there also patient. You have to console them. Role of nurses is there is avoid friction and shear. As I also said, lift the patient, don't drag the patient. Then decrease activity and mobility. You have at least in 2 hours, you have to change the position. If the patient is in a ventilator, change the position. If patient is awake, you have to mobile the patient. You have to tell that patient can be sit on the side sitting of the bedside sitting on a sofa or a couch, not for a long time. Couch, and then you shift the patient, or the patient should be can be walked, or then can be taken on a bed. Interventional patients have decreased sensory perception. The diabetic patients, the neurologic patients have a decreased sensory, then more chances you have to bed sore. You have to see that. Pressure on incontinence, you have to clean it as early as possible. So this is the chart that I have put it. I think it's easy to remember that pressure ulcers, you have to remove the possible and remove the causes. Treat the cause, comorbid condition, diabetes and cardiac cause and renal failure causes. If this sludge is absent, sign of tissue or systemic infection or slug is present, then dressing is to be done. Antibiotics, local antibiotics to be provided. Debridement if is there, if the erosion is there. So healing is there. Then you have to change the position. If it is non-healing, you have to do the skin grafting, or negative pressure wound therapy is also done by the plastic surgeons who have a bed sore of a long term. This is algorithmic of the last part of my slide, how the bed sore is managed in algorithmic approach. Okay, so the pressure redistributing devices to be used like a static or dynamic devices. Mostly static devices is used, but can be dynamic devices rarely used in the ICU. Debridement, if required, some patient the debridement should be done. Then nutrition therapy is to be maintained the patient nutrition status approximately 15 or 25 to 30 kilocalorie per kg is to be maintained if the patient, and the protein requirement like 1.5 to 2 gram per kg is to be maintained. Antimicrobials, if the patient is having a deep tissue or an osteomyelitis of bone, then you have to see for it. Or the complications we can see is cellulitis, bone and joint infection. And at last, I conclude that avoiding a contributing factor to be main important. You should know before that the whose patient is prone to the ulcer formation. Early recognition of the warning signs, determine of the stage evaluation, risk assessment, prevention and management. Role of nurses is to be most important. Prevent it rather better than cure. These are my references to my slides that I've taken from. An ounce of the prevention is worth for pound of cure. You're using your pound of cure for using for the ulcer is better you prevent it. The less pound is used, the less income of the it's kind of safe for the family. So this is my end to my slide. Thank you. So there are big questions, and I over to you, Dr. Tanmoy sir, and the ICCM person. Thank you.
Thank you, Dr. Prateek. It is an excellent lecture, and I think it will be very helpful for all the staff working in ICU, hardworking staffs. Now we have a few MCQ questions for you, all the attendees. You can easily answer after seeing the questions one by one in the chat box, and we can then can tell the answers. Are you ready? In chat box, you can answer.
You can answer, you can raise your hand, or you can write the option. Can we go ahead, ma'am?
Yes, I think next go for first question.
First question.
Yes.
So one of the most important ways to prevent a pressure ulcer is to do a regular skin assessment, provide support surfaces for all, identify at-risk individuals, or do regular repositioning. But the most important way to prevent pressure ulcer is to. You can answer in a chat box.
These all are important, but which one is the most important, sir is asking. I have initiated the chat, and chat, I think someone, if you can answer this. Okay, Jesse is answering A. Josephine Mary is doing D. User D. HP to everyone A. Kumar Mahantes raised hand. Can we ask him directly?
No, sir. He answered it. He answered it B.
B. Okay.
Yes.
I have said that all the
all are important.
four steps are important. So answer is C. And
so answer
please,
is C.
Please give the answer.
Yeah. Yeah. So identify at-risk individual. I have already mentioned it that the patient who is at risk is to be the most important. The first come as a nurses come in the ICU or at the bedside or in charge or team leader aside a patient, he or she should know that who is the at-risk patient. Okay, so identify at-risk individual is used so that you can prevent it better way. Okay, then you have to regular skin assessment. Okay,
all other answer are also important, but this is the most important. We'll go for second question.
So this is second question. So this second question, all at-risk patients should be assessed for pressure ulcers except. All are true, but except is there. All at-risk patients should be assessed for pressure ulcer, like at the time of admission, at regular interval, at significant change of health condition upon discharge. So anyone can answer. It's very easy.
One answer is there. Abiran Roy, Potami, Hemlata. Yes.
So yes, you are right track. So it's D. Upon discharge. Of course, the patient is discharged, then why you measure it at risk patient? The patient is discharged happily. So why you have to check it? So my next question is, in acute care assessment, in acute care, reassessment of pressure ulcers should occur how often? How many times you assess it? Every 24 to 48 hours? Weekly initially, then monthly, every shift, or after patient dies? I think
how often
the answer will be easily given because one option easily went off. So what's the answer?
Everyone is writing every.
So everyone is answering C. So
yes.
It is 24 to 48 hours reassessment.
At least.
Every shift you don't have to come and then you have to reassess. If the patient is at risk or in acute care setting, then in every 24 to 48 hours you have to assess it. Yeah, in every shift you have to see the chances of formation of ulcer. If it is there, then it will take a time. It will not like that it will heal, like it will heal easily or it will heal in a 1 day or a 2 day. You have to take a 24 to 48 hours. So this is true and false. You have to see the false or true. If patients or a resident is found to be at low risk for a pressure ulcer, further reassessment is not necessary. If patient or a resident is found to be at low risk for pressure ulcer, further reassessment is not necessary. It is like that. अगर किसी पेशेंट को अल्सर फॉर्मेशन का बहुत कम चांस है तो क्या हमें उनको असेस नहीं करना चाहिए?
I think everyone is writing it.
So,
Most of the answer
Josephine,
is
Mary,
false.
it's not B. You have to write true or false.
एक बार आपने लो रिस्क बोल दिया, देन आप एसेस करेंगे नहीं एसेस करेंगे? सुधा सुंदरम, प्लीज राइट इन चैट बॉक्स. We are unable
So, I
to
think everyone has
unmute you.
answered. Should I give the answer?
हाँ, it is
So, it is
false.
false. You have to assess it. It doesn't mean like the patient has a low risk, you don't have to assess it. You have to assess it. No? It doesn't mean the patient of low risk can go to the high risk. It can go to it. So, everyone has answered rightly. Right. So, which of the following factors can cause pain when patient or a resident has a pressure ulcer? In which of this the patient having a pain? Pressure, friction, ulcer. You have to remember the stages. Pressure, friction, ulcer, damaged nerve endings, inflammation, infection, or all true. Right. So everyone answered very rightly. So it is all true, right?
Yes.
So it's the last question.
Perfect.
I think it's last.
Yes, sixth.
Yeah, it's last question, right? A red wound bed indicates only the patient having a red wound. Okay. Presence of sludge of fibrous tissue, presence of granulation tissue, infection, or sign of ischemia.
Yes.
You only see the red wound. Indicates what?
I think 4 answer is there. Rachna B.
I think I can show the answer.
User, it is B.
So it is presence of granulation tissue, right? So this is my whole slide on bed sore in critical care. That is most important. So you have to see in your critical care settings or in ICU, every nurse has to be considerate and take it very seriously. To the ICU bed sore, chances are very high, increases the prolonged stay. So thank you all. This is my slide ends.
Thank you, ISCCM team, for this excellent step and session. I think Prateek has done excellent job, extensively speaking on this big issue and very important issue on bed sore in critical care. And I think it will be very helpful for the nurses as well. Over to the manager.
Sir, please ask if anybody have any question, then
yes,
type in chat box.
Yes, you can, if you have any question, you can type it in the chat box and we can answer it. I have seen 20 plus attendees here. You can easily ask if there is any question on this. It is important for day-to-day ICU care, and everyone is facing this. What is grade 1, what is grade 2, we should know.
Okay, someone has said slides are not clear. So I think the network was not okay. But slide must be clear, I think, to everyone. I thought it's visible and to everyone. I think, Tanmoy sir?
I think initial some glitches are there.
Some glitches were there in a voice. Yeah.
But to me, it is audible in every time. but
Okay, sir.
maybe in some
Somewhere
attendees.
there's a network issue is there. Yeah.
So over to you, education team. If it is okay, we
This
can.
what are same? They have one question. What are same causes of foot ulcer? What are
Prateek?
the what are same causes? What are the causes? I think he wants to ask what are some causes of foot ulcer? He wants to ask the causes of foot ulcer.
Diabetic foot. I'm saying diabetic foot Barjas disease, trauma. These are the important causes. Prateek, can you
Yeah, but
say?
in ICU settings, the patient who is supine, the heel ulcers are more common. If you have not properly placed the silicone pads, the long-term ICU patient then can cause the uh, foot ulcers. But yeah, when the patient come in a ICU or in a OPD settings or in an emergency, the foot ulcers most common is diabetic, as the sir has said, and at the Bursar's disease or a low perfusion state, okay, to the vessels, or any varicose vein is also there. It's most common. Okay, and some the Jocelyn Mary is said can do Elvin dressing. Yes, you can do Elvin dressing in ICU. I also do Elvin dressing when there's a bed sore is there in the sacrum part. I put up Elvin dressing. Most common when it avoided the progression of the bed sore or ulcer formation. It static it prevented further progression. Rightly said, sir. Tanmay sir, anything else you want to add?
The idea is when it is dry, you have to wet it, and when it is wet, in aluintation is used in wet ulcers, grade 3, grade 4 ulcer, higher grade ulcer, large ulcer, and you apply it and forget for 5 days, 4 days. Just we have discussed 48 hours to 24 to 48 hours. You have to forget, and you have to heal it. You have to let it heal like this. So aluin dressing adds, it acts very beautifully on these large and grade 3, grade 4 ulcers, and it automatically help to heal. That means you leave it for 4 to 5 days and the area is magically healed with this. There are some
I
clinical
think
interest.
HP want to ask the stress ulcer. So stress ulcer is a different thing. We are here for a bed sore. Stress ulcer is a different thing. It's a ulcer of the stomach for the most common critical ill patients. You can use or avoid it by the other causes or drug induced also, hypoperfusion state also, or may patient most common in mechanical ventilation. Most common causes also there, and patient having a long term on the patient is not taking a nutrition can cause ulcer formation also. So these are the causes of stress ulcer, but the treatment is that according to it, you have to remove the cause first. You have to remove the cause, then every treatment you have to remove the cause first. Okay. And then you have to give a pentoside infusion, or you have to give an alkalizer, or you have to start feeding early. This is the thing.
Perfectly said. Head injury, coagulopathy, these are the important areas where the stress ulcers are common. And it is ulcer in the GI tract. That means with
Yes, yes. We are talking about the bed sores.
with acid secretion in the stomach, and
Yeah.
it is ulcer outside, bed sores ulcers.
So I think we have done with questions.
Yes, yes.
Education, Deepa ji, you